So let's talk about unmet needs in diffuse large B-cell lymphoma. I think we recognise that we're doing very well in large cell lymphoma. We see the benefits of the addition of rituximab to CHOP chemotherapy brings about a 16% advantage in terms of overall survival, which is maintained over a decade. And actually, if we look at some of the outcomes from the study, some of the studies, we see that over 80% of patients with DLBCL are alive and progression-free at 2 years. So we recognise, however, that there are a number of key groups that are failing to benefit from R-CHOP chemotherapy. And those are clearly those patients who relapse after achieving a complete response, those patients who are refractory, those patients who perhaps have molecular phenotypes that confer an adverse prognosis. I think we do poorly also in terms of our elderly and comorbid population. So our focus has got to be saying, well done, we are clearly curing a lot of patients with our R-CHOP or R-CHOP equivalent approach, and really our focus should be to try and improve the outcome of those patients who we predict to do badly or those patients who are doing poorly. So my view is that we are probably not going to make a significant difference from modification in our chemotherapy. We've seen over the years that intensification of therapy with high-dose chemotherapy consolidation really has not proven to demonstrate an overall survival advantage, although some studies have shown a progression-free survival advantage. We've also seen that intensification with treatments such as dose-adjusted EPOCH-R, for example, have some very nice results in terms of single-arm studies, and we really await to see the comparisons. And there's been a study conducted by the CALGB that has compared dose-adjusted EPOCH with R-CHOP, and we look to the results of those in terms of benefit of intensification. In the UK, we looked at maybe increasing dose density with comparing R-CHOP 21 to R-CHOP 14, and we saw no difference in terms of event-free survival and overall survival in terms of the different treatment arms, and certainly couldn't identify any subgroups that were associated with an improved outcome benefiting from the 14-day regimen. So I think the lessons of history probably say to us that just modifying a conventional chemotherapy is not going to be the answer. But actually what we do have is we have a great insight into the biology of diffuse large B-cell lymphoma. So we recognise now patients that may be particularly doing badly, such as those with MYC translocations, and particularly those with MYC and BCL2 double-hit translocations. But also we can recognise a group of patients with DLBCL who will do less well because they have MYC antibody staining or high levels of MYC protein with BCL2 expression. And these group of patients are absolutely ripe for examination in clinical trials. But we also recognise that we've got much more complex models of heterogeneity in diffuse large B-cell lymphoma. We well recognise the gene expression profiling work that demonstrates ABC and GCB, and treated with R-CHOP chemotherapy, the ABC phenotype does much less well than the GCB phenotype. So the question is can we target the molecular aberrations in each one of those phenotypes with the addition of novel agents to see if we can improve the outcomes? So the ABC phenotype, we're really trying to, the whole pathobiology is all beginning to shape out, and we recognise a considerable number of mutations that are present in the ABC, which often result in activation of the NF-kappa B pathway. So there have been a number of studies looking at the addition of bortezomib to R-CHOP chemotherapy to see if you can overcome the adverse prognostic features of ABC phenotypes by addition of bortezomib, and that certainly can look like the case in phase 2 trials. And actually in the UK we're currently looking at the addition of bortezomib to R-CHOP chemotherapy in patients that are stratified prospectively according to the cell of origin. We recognise that the BTK inhibitor ibrutinib has demonstrated some single agent activity in diffuse large B-cell lymphoma in the relapse and refractory setting, and that seems to be a preferential effect for the ABC phenotype. So currently there are investigations going on, phase 3 studies looking at the ABC phenotype and seeing if the addition of ibrutinib to R-CHOP may actually result in a progression-free survival advantage. And very similarly with lenalidomide, single-agent activity in the relapse and refractory setting, now being investigated in the first-line setting with R-CHOP chemotherapy in the ABCs. The dysregulation of pathways, oncogenic pathways in the GCB phenotype are less clearly understood. But what we do recognise now is that there are mutations in EZH2 which occur exclusively in the GCB phenotype and probably occur in about 22% of patients. And there are inhibitors of EZH2 that are being investigated by a number of sponsors, and it may well be that we develop a target here for the GCB phenotype. So I think, my view on this is that by understanding the biology of diffuse large B-cell lymphoma and the correct stratification of patients prospectively, we are going to be able to improve our outcomes in patients with DLBCL.